So good morning, everyone. We are presenting on TLIF, also known as transformational lumbar interbody fusion. I'm Abby Mitchell.
I'm Madeline Pierce.
And I'm Zakiria Oliver.
So TLIF is a surgical procedure used to stabilize the lower back and relieve nerve compression, taking two or more vertebrae and fusing them into one single bone. And so there's a few reasons why people might be needing the TLIF procedure. So slip vertebrae, or one of your vertebrae, slips forward onto another, creating nerve compression, along with worn out disc. We've mentioned intervertebral disc a few times already, but basically those can just be worn down over time and causing bone-on-bone friction. Another is narrowing of the spinal canal, and so there might be bone spurs or thickened ligaments in the area crowding the nerve where the nerves are located, and so the surgery would be used to take that compression off of those nerves, along with repeat disc herniations, where if you have the same disc hurt multiple times, that part of your spine can become wobbly and it might need a more permanent fix. Along with structural instability, if your spine's just like not able to support your back and you have mechanical back pain that's not improved with rest, you might need a more permanent fix also. Along with nerve compression, you've probably heard my dad's had pinched nerves, and usually they're fixed with shots or physical therapy, but if that can't happen, then you might need a more permanent fix also.
Can we hold there just
Yeah.
a second? So if you have nerve, I want to make sure everybody understands. So this one right here, transforaminal lumbar interbody fusion. So the first two presentations were cervical, up here in the top of the spine, lumbar being the bottom of the spine, right? Up, like your next 5 levels above your sacrum. Transforaminal, right, is the right thing, right way to say it. But I want you guys to understand what that means, right? So foramen is part of that word. Foramen is where your spinal cord goes down, right, and or your nerve roots. There's a foramen there as well. So we're going we're going across the foramen to do a lumbar interbody fusion, right? So the same steps we just did in cervical, right? We still have a disc herniation, we still want to remove a disc, we still want to decompress. We're going to tear a bunch of stuff up in the process, and then we got to reconstruct it, right, infuse it. So just wanted to kind of hit those terms there. Any comments you make so far? Yes, okay, awesome, great, thank you.
Okay, so a little anatomy before Madeline gets into the steps. Obviously this picture is so blurry, but we have our vertebrae. The TLIF procedure is usually done on the lower back just because that tends to be where most of our stress occurs. I know I have lower back pain. I'm sure y'all do from looking at computers all day.
These presentations don't help. Like your back is twisting.
And then here's the intervertebral disc we were talking about. They also they're called shock absorbers or jelly disc in layman terms. Then also your spinal nerves are your wires to your legs, and so a lot of the time that's what the surgery is for, is really relieve compression on that. As you just mentioned, this is the foramen. It's kind of used as a window exit hole and used strategically throughout the procedure. And then there's pedicle bones, which are the support bones of the spine. That's where the titanium screws that Madeline's going to mention are put in. Along with the lamina is the top bone of the spinal canal. And in surgery, it can be shaved or even removed to help relieve pressure also.
So I'm going to talk about the hardware and the implants that are typically used. So first are the interbody cages and spacers, which are placed between the vertebrae. And then we're going to use pedicle screws, which are going to go into the bone, and then we use rods to connect those screws to have stability. And then we're going to use bone graft materials, and so this consists of autograft, which is the patient's own bone, or allograft and synthetic graft, which is a donor bone. And then lastly, we might use minimal invasive tools for to place implants into smaller incisions. So now we're going to go through the steps of the procedure. So step 1 is you're going to make an incision into the lower back and a few inches to the side of the spine. And then we're going to separate the back muscles to make the spine access easier for us. Next, we're going to open the spinal canal by removing the lamina and facet joint. I don't know if I said that correctly. Step 4, we're going to gently move the spinal nerve aside. And then we're going to shave a thin layer of bone, like Abby mentioned, from the vertebrae to make room for a replacement disc and place a plastic room between the vertebrae. Then we're going to prepare the bone graft material into another kind of spacer that is called a cage. The cage will hold the bone graft material that will be placed between the vertebrae. Next, we're going to place 2 sets of screws into the bone just above and below the affected disc, and then place a rod between these screws for stability. These screws and rod will help keep the vertebrae pretty stable while bone graft makes new bone. So step 8, we're going to release the back muscles back into place, and then step 9, we will close the incision. And then here's just
So just like any other procedure, obviously there are risks. You have your general surgery risk, which would be infection, excessive bleeding, blood clots, and obviously reactions to anesthesia, but you also have your nerve-related risks, such as nerve injury, numbness, tingling, or leg weakness, persistent or worsening pain, and a very rare risk of paralysis. So procedure-specific and long-term risk would be hardware and fusion complications. So that would be like screws or rods loosening or breaking, failure of the bones to fuse, and possible need for a revision surgery. And some other potential complications would be a spinal fluid leak, paraspinal iatrogenic injury, adjacent
Nice
segment.
job.
I know, I was practicing it. Adjacent segment disease, reduced lower back flexibility, ongoing or chronic pain. And we also have like the percentage of these things happening. So with the highest being an incidental dual tear, but 3.8% spine infection, 2.1% screw misplacement, and 1.8 interbody cage migration.
It's really good. I'm glad you guys put this slide in here because it can apply to like the ACDF procedure as well. Whenever we're trying to do a fusion, right, this is what the doctor's thinking. I've got to do everything I can to get that arm to heal, right? I'm putting a cast on, I want it to grow. So all these things, I want it to heal. And heal means grow bone or fuse. If it doesn't fuse, we have a problem, right? Because that hardware by itself is not going to be able to hold that patient together all that time. Like we need the fusion to happen. So there's all these things that happen. I mean, you have somebody that smokes, or somebody's got nicotine issues, somebody has diabetes. I mean, there's all these things that can keep them from growing bone. That's what the surgeons are freaked out about, right? So they're thinking like, how do I go in there and best prepare this thing to give me the best chance for fusion? So their complication could be 6 months after the procedure. Patient calls and we're like, hey, I've got a problem. I felt something pop and I'm hurting, and they come in, they do an x-ray and like, oh, your hardware loosened or broke or whatever, so that's a bad day. Now we're going back into surgery. So those are great. I mean, I think that applies even in the cervical spine, right? That's what surgeons are constantly worried about is revision surgeries. Great job.
So the recovery after TLIF surgery, so immediately after surgery, from some sources say like within 24 hours you might be good to go. And some people
That's the
are
surgeon you want to go to.
and some people are there for a good little meeting. So it just varies. Hospital stay can be 1 to 3 days. And you're also going to focus more on the pain management and early mobilization. And so like they try to encourage you walking as soon as possible. Within those first 6 weeks, you have limited BLT. That was kind of funny to me. Bending, lifting, and twisting. Gradual return to light daily activities, and you might begin physical therapy. And all the way up to 12 months, the bone fusion continues to develop. You go check in and see if you have any issues with that. Increased strength and mobility, and gradual return to work depending on what you do. It all just really varied by the patient and what like background they had, what they needed it for, and other health issues surrounding it. So results and long-term outlook. So expected outcomes obviously is to reduce that nerve pain, especially in the leg, improve spinal stability, and a reduction in chronic back pain and improved mobility. The timeline for results really, like I said before, vary by patient. Pain relief may begin within the first few weeks, and the full fusion can take 6 to 12 months. And the success factors is 85 to 90% feel better right after surgery. Consistent physical therapy, obviously, and going to necessary check-ins. And then lastly, some surgical factors that can affect the success, obviously, is the implant placement, adequate nerve decompression, etc. And that's it.
Awesome. Great job. I know if y'all covered like the patient symptoms, right? So you talked about the it could be a herniation, it can be a pushing on a nerve root, but what is the pain that a patient would have that needs this procedure? Does anybody know? How would they present? Like, I hurt where?
I know when my dad had a pinched nerve, he actually felt it in his arm, and then
From his
they
neck.
would.
So he
Yeah.
had a cervical issue, right?
Mhm.
It's perfect, right? And I'm glad we hit this. And it's a lumbar issue. And if it's a pinched nerve, where does that pain show up? Does anybody know? Down your leg. It could be your butt, it could be down your thigh,
butt,
all the way down to your toe. And so for you guys to know, right, we talked about that spine has all these nerve roots that send signals everywhere in the body. If it's up here in the cervical spine, it's in the upper extremities, in your arms. A lot of people get a cervical disc herniation and they're like, I think I tore my tricep. No, you didn't. You got a disc herniation, right? Same in the lumbar spine. I think a lot of people think like if I had a back issue down here, I had back pain. Yeah, you could, right? But when you have a really bad issue, they're like, my thigh is killing me. Like I've had all this pain. Or it could be